Thank you for the opportunity to present a case at CBI 2020. My name is Mohsen Chaudhary. I'm one of the interventional cardiology fellows at the Bethesda Deaconess Medical Center in Boston. I have titled our case, Keep Calm and Don't Inject. I don't have any disclosures. Our patient is a 66-year-old woman with lupus and Sjogren syndrome who presented to the cath lab for elective coronary angiography for evaluation of progressive angina and an abnormal stress test. You can see the details of her medical history here. Here is the summary of her evaluation prior to the coronary angiography. As you can see, her resting electrocardiogram is unremarkable. Her stress test was notable for chest pain and ischemic ECG changes. Her basic labs as well as physical exam were also unremarkable. Given the routine case, we went with a right radial artery access, a 6 French slender sheet, and a JR4 diagnostic catheter. You can see the initial injection of a right coronary system. As you can see, our diagnostic catheter here is deeply engaged. And shortly after this picture was taken, patient had rapid clinical deterioration. She became tachycardic, hypotensive. There were ST segment elevation on the EKG leads. And as you can see, she became very sick very quickly. Her systolic blood pressure went down to the 40s. What would you do next? We gave her atropine. We started her on a dopamine drip. We got right femoral artery and left femoral vein access. We put in a temporary transvenous pacemaker. But despite above, she remained hypotensive and had to be started on a norepinephrine drip. She also got very agitated and had to be intubated sedated. With all of this, she stabilizes transiently. What would be your next step? For us, we thought that the reason for her clinical deterioration was due to a catheter-induced dissection of the RCA. We took a JR4 guiding catheter and a pro water wire. As you can see, our guiding catheter is not selectively engaged, and this is on purpose. We wanted to avoid any further anterograde injection after we have recognized the dissection. Fortunately, we were able to very quickly wire the vessel with the pro water wire. As you can see, our wire tip movement distally, we are very confident that we were in the true lumen. At this point, we took a 2.5 semi-compliant balloon and started by ballooning the proximal section where we thought the dissection started. Despite the initial ballooning, there was no flow into the vessel. At this time, we proceeded with IVUS. And as you can see from our IVUS here, we are able to see that we are in the true lumen with our wire. You can clearly see the dissection flap. And you can see that there are branches coming off the lumen where our wire is. Our other reason for doing IVUS at this time was if we were not in the true lumen, we plan to use the IVUS to guide us into the true lumen with our wiring. Knowing that we are in the true lumen, we went ahead and further ballooned the vessel with a 3O semi-compliant balloon. Despite all of this ballooning, there was no flow into the vessel. At this time, we took a microcatheter and took a distal tip injection. This is a step that can be debated. As you knew from our IVUS evaluation that our wire was in the true lumen, but this is another way to confirm wire position into the true lumen. As you can see from our distal tip injection, we were very, very confident that we are in the true lumen. So we went ahead and stented the vessel initially with a 3O38 Zions from distal to midsection, as well as a 3O33 in the Zions stent in the proximal section. After the stents were placed, we were able to restore flow into the vessel. We post-dilated our stents with a 3.5 NC balloon and optimize our stent with IVUS. This is our final result after the IVUS optimization. Don't forget, we still have not seen her left coronary system. So we took a JL35 diagnostic catheter and took pictures of her left coronary system. As you can see, she has a very tight lesion in her proximal LAD, which was likely the cause for her initial symptoms. But we did not treat the lesion as there was good flow distal to the lesion. And at this time, we have already used significant amount of contrast and she has been exposed to significant radiation. I wanted to take a second to go over an algorithm that can be used in case of coronary artery dissection. The most important step after a coronary artery dissection has been recognized is not to take any further anterograde injection. Of course, we want to offer the patient appropriate hemodynamic support. We want to avoid deep guide engagement. To take guiding catheters, they are passive. As you know, deeply engaging aggressive guiding catheter can make the dissection worse. We also want to wire into the true lumen with non-hydrophilic wires. Now, after initial stabilization and wiring the vessel, an IVUS examination can be very helpful. IVUS can confirm the wire is in the true lumen, or if it is not in the true lumen, IVUS can be used to guide wire into the true lumen. If we are able to wire into the true lumen, the next step is to stent the vessel. If not able to wire into the true lumen despite IVUS utilization, the options are to conservatively treat, consider CABG, or use some of the bailout strategies, that is retrograde approach if there is collaterals, or re-entry techniques with specialty stringed device, or re-entry using wire-based method. If we are able to wire into the true lumen and implant stent, and if there is residual dissection or hematoma, this can be left alone. If there is good flow distally, additional stenting can be considered, or a cutting balloon to release the hematoma can be considered in this case as well. Back to our patient, post-PCI, her hemodynamics were very reassuring. We did not think that she needed further mechanical circulatory support. She was able to come off the vasopressors very quickly. Here is her echo post-procedure. As you can see, she has infralateral hypokinesis and LVEF of 40%. She did very well post-procedure. Her heart block resolved shortly after the second stent was placed. She was admitted to the CCU, but was able to be extubated and transferred to the floor very quickly. Had an unremarkable hospital course and was discharged on hospital day 4. She continues to do well on 6 months follow-up. Interestingly, her chest pain has significantly improved and her LID intervention was deferred for the time being. Take-home points from this case: catheter-induced coronary dissection is rare, but can be potentially life-threatening complication. Immediate recognition and avoidance of further anterograde injection is essential. Keep calm and don't inject. Management of complex dissection can be very challenging. Stenting is usually the preferred treatment in most cases. CABG or even conservative management can also be considered. It is essential to have a clear algorithm for treating this complication should it occur. As often, we have to act quickly and don't have much time to think. Thank you for this opportunity and thank you for your attention.